With infectious disease emergencies, there's a bunch of different ways you can actually approach this. You can think about an emergency in the context of septic shock or neutropenic fever, but we've seen that time and time again, and it just really wouldn't be that fruitful to talk about those types of conditions, especially since we'll see septic shock with just about every disease we'll talk about today. What I wanted to do was talk about those specific infectious disease emergencies where ID physicians will be at the forefront of diagnosis, management, treatment, as well as prevention and control. So we wouldn't really be able to talk about emergencies without talking about those that can cause pandemics and without talking about bioterrorism. And hopefully those are the calls that we will never get, but it's very possible. So hopefully we'll get a little bit of participation, and we all hate that, but we're going to do it. Does anybody know where this is? It's a university. There's this. Those are the only two I have. No, it's not Boston. It's an Ivy League school. Princeton. Yep, Princeton. So does anybody know what happened really significantly in Princeton in the last few years? It was meningitis. Back in 2013, there was a significant number of cases of meningitis. What was remarkable about this is that the serotype that was involved was Serogroup B, which is a little atypical within this country. So there was a huge frenzy about what to do, how to control this, and how to vaccinate for this in those that weren't infected. There was a death, I believe, in Drexel University that was tied to this Princeton outbreak back in 2013. So the way they approached this with vaccination was they did an investigational new drug with Bacillus to just a significant number of students who went to Princeton University. And that's how they controlled it. So our first disease is meningococcal meningitis. It's a very important one. Just a little bit of history, which we'll go through with a lot of these diseases we'll talk about today. So interestingly enough, meningitis was not really seen with the Neisseria organism prior to 1805. So it may be a relatively newer infection in terms of infectious disease. It was first described in 1805 in Switzerland, and then there was more outbreaks that occurred after that. In 1806, there was an epidemic right here in Massachusetts, in this country, and we frequently see meningitis outbreaks in the meningitis belt of sub-Saharan Africa. It was first called a Diplococcus intracellularis meningitis, back before they knew exactly what it was. And there were a lot of outbreaks that occurred during World War I. What really revolutionized therapy for meningitis was sulfonamide therapy. However, it quickly developed resistance. And later on, it was determined that the specific group that these diseases fall into depend on the capsular polysaccharide. It's a gram-negative diplococcus, an obligate human pathogen, and it is actually carried in a lot of people's nasopharynx, up to about 25%, some estimates state. It produces a polysaccharide capsule, and the structural differences are what really cause these to be pathogenic. They grow in ideally 35 to 37 degrees Celsius and 5 to 10 degrees percent CO2, and they grow on the plates that you see in front of you. There are specific clonal types with each of these serogroups that are the actual causes of the infectious disease part of all this. And there are 12 that cause most of the outbreaks throughout the world. These are the major factors that determine its infectivity. Colonization. There's actually some statements that say if there is no colonization, there is no disease. Virulence factors, transmission and acquisition, and human susceptibility. So the major virulence factor is the capsular polysaccharide, and there's 13 specific serogroups that are identified. However, 6 are responsible for essentially all invasive disease, which is meningococcemia as well as meningitis. The endotoxin LOS is really the major virulence factor also, and you can measure levels of this endotoxin and correlate it with the risk of mortality. Up to about 25% may actually be colonized in the nasopharynx. And transmission is with large respiratory droplets. And you can see the disease about 1 to 14 days, anywhere in between, after you actually acquire this infection. The absence of any type of antibody response or complement system is really the most important factor in determining the severity of this illness. You can have people with preparedin deficiency, the terminal complement pathway deficiencies, beta-2 adrenoceptor genetic variations, and the more important thing is there are a lot of other immunosuppressed states that increase your risk for getting meningitis, which we often neglect, such as glomerulonephritis, hypogammaglobulinemia, splenectomies, and HIV patients. The serogroups B and C are the ones that are most common in the US and Canada, more so C than B. And that's what was remarkable about the outbreak in Princeton. Everyone thought it would be C, but was a bit alarmed that it was a different serogroup. Serogroup A is responsible for the most epidemics, and Serogroup B has now been determined to be the most significant in terms of prolonged outbreaks and hyperendemic disease. The problem with actually developing a vaccine, especially against Serogroup B, is that there's a lot of diversity among the specific serogroup. The B capsule has a similar structure to human polysialic acid determinants, and the ST11 isolate, which is on serogroup C, can somewhat go through a capsule switching to a serogroup B capsule. And so it becomes a little difficult when we actually create vaccinations, particularly against the serogroup. Meningococcemia is a disseminated disease, mostly caused by B and C, and the time window between initial symptoms and death can be hours. There was actually a case when I was in residency of a hospitalist who ended up becoming severely ill, and within a matter of a day went from the floor to the ICU to precautions and death, all within about 24 to 48 hours. It's a bit remarkable because there really wasn't any signs of this coming. And there's actually a scholarship fund that's created in her honor. You can see a rash develop anywhere between 40 to 80% of cases, but the problem is it could be difficult to really identify initially. And it's tough to know if it's a petechial rash from the disease itself or a purpuric rash from DIC. Regardless, it's severe. The rapid bacterial growth is what can cause the circulatory collapse and coagulopathy. And it can lead to a purpurofulminans presentation in which you actually lose digits, limbs, and such. Meningitis is the other form of severe disease with Neisseria meningitis, obviously. You can see a triad of symptoms in only about 27% of cases. And it actually has a high concentration of endotoxin within the CSF. You would also potentially need steroids in the event that you develop cerebral edema, cranial nerve deficits, particularly cranial nerve 8. And this is some of the things that you may be able to see. In the top picture is the ecchymoses that you can develop. The B is adrenal hemorrhaging, which you can see with this organism. And C is a lot of the dry gangrene that you can see. These are some more pictures of the type of rash that you should really be familiar with when you talk about Neisseria meningitis. Treatment? I believe most of us are familiar with this. Ceftriaxone is pretty much the mainstay as of now. Cefotaxime. A lot of the isolates are still susceptible to penicillin. Meropenem and chloramphenicol, which is not available in this country, are also potential options. Now, how long would you potentially treat for? Some people say that you can potentially treat for 3 to 4 days and stop. I don't know if I would feel comfortable with doing that. Other estimates really kind of point to 10 to 14 days, even longer, depending on the severity of illness. Interestingly enough, as soon as you start IV therapy, organisms are killed within a matter of 3 to 4 hours, which is why it's super crucial to start antibiotics as soon as possible. You can see a decrease in endotoxin concentrations by about 50% within 2 hours. In certain countries, they actually advocate for pre-hospital antibiotics with IM ceftriaxone as the mainstay. No role of plasmapheresis, and there's really no demonstrated benefit of Decadron. Chemoprophylaxis, I believe we're also familiar with this too. This is probably what we'll be called on mostly when we have an outbreak of this. Rifampin, ceftriaxone, Cipro, and azithromycin are all potential options for chemoprophylaxis, but the question is, who should get it? So anyone with a close contact, and it's usually defined that at about 3 feet, and those with prolonged contact, such as household members, and those directly exposed to the patient's oral secretions. So hopefully we'll not be the ones to do endotracheal intubations or CPR on these patients, but if we were, we would be the ones that would need prophylaxis. Medical staff, household contacts, daycare centers, oral secretions that we're exposed to, and then the droplet precautions associated with this disease. They're usually recommended for about 24 hours after initiation of effective antibiotic therapy. One of the more complicated aspects of all this is vaccination. What to use, when to use it, who to use it for. So the more common vaccine that's out there is the MEN-ACWY, which is used for the more common isolates that are available out there. And there's a 2-dose primary series, about 2 months apart, and the goal is to revaccinate every 5 years in those particular patient populations. Anatomic or functional asplenia, persistent complement deficiencies, and adults with HIV infection. You can give them 1 dose and revaccinate every 5 years if you're a part of the second group, microbiologist, a recent outbreak with that strand, adults who travel to endemic countries, military recruits, and first-year college students. If you're 56 or older, haven't been previously vaccinated against A, C, W, and Y, they actually recommend getting the MPSV4 for 1 dose. Now the Serogroup V vaccine, which was a lot more iffy a few years ago. But now it's becoming a little bit more mainstream. They recommend a 2-dose series, and that's what was special about Bexsero. It was advertised as the only 2-dose series for Serogroup B, as opposed to the others that required at least 3 months, 3 different vaccinations. So in those who have anatomic or functional asplenia, they recommend a 2-dose series of the Bexsero, at least 1 month apart, which is also one reason why this was preferred. Microbiologists, they also recommend the same for those with around a recent Serogroup B outbreak, and those between the ages of 16 to 23 that are otherwise healthy. Now, they haven't come up with guidelines about when to revaccinate for Serogroup B. That's pretty much it for this particular infection. The next one that we're going to go to, I believe that we're also very familiar with, is Ebola. More so viral hemorrhagic fevers. So I think we can all remember all the headlines that were out there in the last few years about how significant this would be worldwide, how we should all be getting a lot of the hazmat suits and being ready for everything to happen. And there was a lot of newspapers about, news studies about the specific infection. It led to a bit of hysteria, and they actually advocated by some to eliminate people from entering this country who held a passport from West African nations. I don't believe that occurred. I just think that this particular individual is just very angry all the time. Maybe that's why he's doing it.
Not just angry.
Yeah. But I think that's all we're going to talk about that. And it actually became so mainstream that it became popular. So this is the New York Daily News, and it's becoming so popular, it's on the same cover as Sofia Vergara, which is a pretty big accomplishment for infectious disease. So that leads us to viral hemorrhagic fevers, particularly Marburg and Ebola is what we're going to talk about. There's a lot of others, but this is the one that's reached headlines more recently and I think is more pertinent to talk about. So viral hemorrhagic fever is fever, malaise, myalgia associated with significant blood coagulation disorders that can rapidly proceed to death. These two belong to the Filovirus, enveloped, non-segmented, negative strand RNA viruses, and the most important ones in this family is Marburg and Ebola. The fatality rates can go up to 90%. And the problem with this is that we don't really fully understand the natural history of these infections. These are 2 of the 4 viruses listed by the U.S. Department of Health and Human Services as a Tier 1 Category A select agent. So that's essentially the highest level of bioterrorist potential. And there are 2 others, but does anybody know what they are? They have to guess. I think Robert talked about it a little bit. Yeah, variole, major, minor. Now, I didn't go too much into these 2 because Robert did a pretty good job about it the last time he went up here, so I can reference it to Dr. Robert Castro's presentation. So the Marburg virus, first documented in Marburg, hence the name, in Frankfurt, Germany in 1967. This was more of a laboratory exposure, but in 1998 to 2000, there was an outbreak in the Democratic Republic of the Congo associated with the workers in an underground gold mine. There were 154 cases documented, and the fatality rate was 83%. So when we go through all these, just pay attention to the mortality rate, because that's more striking than anything else. In 2004 to 2005, in northern Angola, 252 cases with a 90% fatality rate. And so this particular strain in Angola was one of the reasons why they were having so much trouble in finding any type of vaccine or treatment options. Ebola. So this is a more quote-unquote sexy topic compared to Marburg, because it was more recent. So this one was first recognized also in 1967 in the Democratic Republic of the Congo in Sudan, and there was associated secondary transmission. More common species at that point were the ZBOV and the CBOV. And in those outbreaks, there was still a pretty significant mortality rate for both types of species. In 1989 to 1990, a new type of species was discovered, the REBOV, and that was in Reston, Virginia. But this was related to samples of animals that were obtained from overseas. In 1994, there was a SIBOV, I don't know if I'm saying that right, also along the coast of Africa. And in 1995, there was a huge outbreak in the Democratic Republic of the Congo, which has gotten a huge brunt of a lot of this, that had an 81% fatality rate. This is the biggest one, 2000 to 2001 in Sudan. A CBOV outbreak affected 425 individuals, and over 200 of these people died. In 2007, there was another species, a BBOV, and this is more of a probable outbreak. They could trace it back possibly to the species, but they couldn't be certain. And that was in 2012 that this outbreak occurred. It was discovered in 2007. The most alarming part of all this was in 2014, the ZBOV spread from its home to West Africa. So the question is, could it spread any further? So the countries that were most involved at that point were Guinea, Liberia, and Sierra Leone. So in the headlines, particularly those that we can see in our news stations, there were about 5 individuals that died, and they could trace their essentially home back to the United States. Patrick Sawyer was the Liberian Minister of Finance who was taking care of his sister who had Ebola. He ended up becoming infected, and he died within 5 days. Dr. Kent Brantley, this is the person that you may have known about in the news a lot more commonly. He was working in Liberia, and he became infected and was treated at Emory University. Highly publicized, and he received a ZMapp, which was more experimental at that stage. Along with him, Nancy Wright-Ball, who was also working in Liberia, also was treated at Emory, also received the ZMapp. Dr. Rick Sacra was working in Liberia, was infected, and he went to Nebraska. Now, he wasn't treated with the ZMapp. He was treated with more of a, I believe this is a antiviral that is no longer on the market. I think the company essentially became defunct. And he, despite receiving this therapy, was essentially cured, but he had a lot of comorbidities after that. He was weak, couldn't be at himself, and he received a blood transfusion and plasma from Dr. Kent Brantley, even while he was being treated. There was an unnamed WHO physician that became infected, who went to Emory also, and Ashoka Mukbro is a freelance camera operator. He became infected and went to Nebraska. So the presentation, you can have an incubation period of 2 to 21 days, sudden onset fever, malaise, myalgia, you can develop a rash, and you can eventually and likely will develop coagulation disorders. There's a lot of lab abnormalities, elevated LFTs, leukopenia, lymphocytopenia, thrombocytopenia, and there are potential ways to diagnose it. The problem with this is that we're not really sure how it gets into our body, but we know that it can be from human-to-human contact. There's a lot of ways that we can get it. We just don't know how it actually happens. It can go through a lot of mucosal surfaces, abrasions, lacerations, parenterally, and it's thought that they actually go and replicate in monocytes, macrophages, and dendritic cells right on your cell surface. You lead to a significant lymphoid depletion and necrosis, and you can have involvement of a lot of organs, especially the liver, which may contribute to a lot of the coagulation disorders. There's councilman bodies that are found in the liver, and these are more of a necrosed hepatocytes, and they're in the bottom image where the arrows are. It's a little tough to see because you're probably small, but it's like right in the middle. Then we led to SARS, which is a lot still a little bit before this time, but it was a huge deal. It was actually popularized in Scrubs. I don't know if you watched the television show, but it was there too. And stands for Severe Acute Respiratory Syndrome Coronavirus. We'll just call it SARS. So the epidemic began around 2002 when they felt as though there may have been game market animals involved, and it may have been traced back to the bat virus, to palm civets or raccoon dogs. And the first person was in Guangdong province in the People's Republic of China. So this person went to Hong Kong, infected a lot of other individuals, and then the disease went from person to person in a lot of other facilities. Healthcare workers and everyone associated with that, family members, people living close to one another, markets, airplanes, hotels, and they felt it was related to droplet or contact transmission. You can see the effects about 4 to 7 days after you actually get the infection, associated with fever, headache, malaise, and myalgia. You can develop a cough, shortness of breath, and then involvement of a lot of other organs, develop leukopenia, a panlymphopenia, and thrombocytopenia. Interestingly enough, you can find this virus by PCR methods in the blood, stool, urine, and respiratory secretions. And the diagnosis is most easily done in the second week of the illness. A lot of people can develop ARDS, but these are more so those people with a lot of other comorbidities. So PCR, a pretty popular way that we can actually diagnose SARS. And you can get IgM and IgG antibodies, which may be transient and a little bit tough to actually get positive results for. No role in any other treatment except for supportive care. The last country involved, June 2003, was the time in which that occurred. And the last known case that we know of is in 2004, but this was more of a laboratory exposure. So as soon as we got done with SARS, kind of waned, lost popularity, we thought everyone was in the clear. And then we developed MERS. Does everyone recognize this? So the Middle East Respiratory Syndrome Coronavirus. Same family, but a different disease itself. So that's the whole name, but we'll just call it MERS. So the first report was an individual from Jeddah, Saudi Arabia. Developed pneumonia, died of respiratory and renal failure in June of 2012. The sputum that he had cultured grew a beta coronavirus that was similar to a type of bat coronavirus. There were more than 500 cases as of then, and about 150 were fatal. Most are in the Middle East. There were a couple of cases in the United States. Now these individuals actually went overseas, came back, but there was one case of secondary transmission in an individual related to one of these other people. They feel as though there may be camels involved in the transmission of this disease, but they feel as though the spread may be more related to hospital environments rather than just a casual contact. You can develop mild upper respiratory symptoms initially, then develop, similarly to SARS, respiratory failure, ARDS, also a pericarditis, which was interesting. Diagnosis should be made in conjunction with the CDC, and with SARS along with this, the treatment is really supportive. So we talked about SARS, MERS, Ebola, meningococcal meningitis, all emergencies. So I actually think the next one is probably the most fearsome, because I think this is probably has the most potential from causing the most amount of death in as little time as possible, and it's easy to do. So back in 2001, big year, we had the 9/11 World Trade Center attack, and everyone was worried about terrorism. And at first, the terrorism was in the form of a lot of mechanical modalities, like we saw with 9/11. And then this happened. Does everyone know what this is? What happened with this? So a lot of letters were mailed, and they took the guise of an elementary school, which is probably the most alarming part of all this. And it was delivered to media outlets, a lot of representatives of the capital, and in it were anthrax spores, viable anthrax spores. And it led to a huge concern about, we are terribly unprepared for this at the time. And this could eventually killed just essentially hundreds of thousands of people if really gone as it was. So I'm going to take you a little bit ahead in time. We had this occur, and this was just a couple of years ago. So FedEx was delivering what they thought was inactivated anthrax spores to different sites throughout the country. Turns out those anthrax spores were actually biologically active. And the scary part of this is that it was being delivered by airplanes to a lot of these facilities. So imagine if something happened to that airplane, you got these spores released on major cities, and you can see a lot of death and destruction. So obviously FedEx profusely apologized, but I don't know. I wouldn't want this to happen. So that leads to our next infectious disease emergency, pulmonary anthrax. And I wanted to specifically talk about pulmonary anthrax because that's really where this bioterrorism lies. Bacillus anthracis is a gram-positive bacillus. The colonies can have a characteristic Medusa's head appearance or comet tail, which possibly maybe what comes up on boards. And the spores can remain viable for years. I have a story about this. And a lot of the pathogenic factors involved is a protective antigen, edema factor, and lethal factor. So the combination of these three is what really leads to a lot of this lethality in this organism. This is on the left. You can see that comet tail, that smear of lines coming out through these colonies. Also similar to what they called a Medusa's head. For those who are unfamiliar, it's the Greek mythology of the lady who had snakes all over her head, and you look at her, you turn to stone immediately. So the spikes are supposed to, I guess, represent the snakes. And the other image are these whipped egg white appearance that you can also see. This is actually what it looks like on a stain, and the bacillus can look as a very long strain on these stains itself. So a little bit about it as a bioterrorist agent. The Germans actually used this by trying to infect horses and cattle and sending it to the Allies in World War I to try to help spread the disease. The next one was a little bit more bizarre. There was a Finnish independence activist named Baron Otto Karl von Rosen. In 1917, what he did was he made a lot of sugar cubes. Inside these sugar cubes, he put a lot of capillary glass items, and he put anthrax in them. And the goal was, as the British Army was sending reindeer and horses with weapons potentially through the country of Norway, he would give these sugar cubes to these animals. They would bite it, break the capillary glass tubes, and spread the disease. However, it was eventually thwarted, and interestingly, 80 years later, they could still see viable anthrax spores from these capillary tubes. So it can last a pretty long time. During World War II, the British actually did bomb experiments on Scottish territory with these organisms, and it contaminated the area for decades. The Japanese intentionally infected residents of Manchuria and China. Quite inhumanely enough, they created anthrax-laden chocolate to try to infect children, which was unsuccessful. The Soviet Union was responsible for the biggest anthrax catastrophe when they inadvertently released spores in Sverdlovsk, Russia, and there were 70 cases of inhalational anthrax. And at the end of the Gulf War, we discovered that Iraq was putting these into munitions. Some more. This is the one that we were actually more concerned about. In 2001, the U.S. Postal Service mailed anthrax-laden letters to really just different outlets throughout the country, infecting 22 people. 11 with pulmonary anthrax, 11 with cutaneous anthrax. 5 deaths, a lot more exposed, a lot more prophylactic therapy. This is where we can save lives. An infectious disease physician first considered the diagnosis when a Florida man had gram-positive rods in his CSF. So he put the two and two together and probably saved the day. The concern about this as a bioterrorist agent is how it can be spread. Powder, liquid, can infect animals from airplanes, sent through the mail, and it can be highly efficient. You can have 100 kilograms of this spore released by a plane would kill about up to 3 million people just from 100 kilograms. And it can affect people about 160 kilometers downwind. Now, how much spore can you really need to cause disease? We don't really know, because in 2001, there was a 94-year-old female in Connecticut that developed anthrax 35 days after the last anthrax-laden letter was discovered. So she may have had a small burden of disease that kind of lingered around until she actually became infected, but we just don't know. How does it manifest? There's an early prodromal stage, flu-like illness, low-grade fevers. Then you develop an intermediate progressive stage with high fevers. This is when we can see a lot of the mediastinal widening on x-rays, and we can see pretty significant pleural effusions. The pleural fluid, if you were to get a culture, it would have a huge amount of bacilli in it. And there's a late fulminant stage after that with overwhelming sepsis and death. This is one person who went to the hospital, and this tracks that person's x-rays. This is from, I believe, JAMA. So the first was the initial ER visit. Looks fairly okay. There might be some disease that's brewing around. But by the next morning, you could see more involvement, more so of the hilar area, with some mediastinal widening. Then later that day, by a matter of 4 hours, you see more involvement within the lung. Then you see even worse involvement of the same lung. And this is a CAT scan of the same person, and this is shortly before he died. There's a huge pleural effusion, mediastinal widening, and really can't survive much longer. So antibiotic therapy, when you see someone with severe anthrax, you got to give them triple therapy. That's really what they recommend. Consisting of an intravenous fluoroquinolone, they prefer Cipro, a carbapenem, they prefer meropenem, and a protein synthesis inhibitor. And they argue for linezolid in case there's meningeal involvement. For bioterrorism associated anthrax, they recommend empiric use of Cipro and Doxy. And if you think about it, it makes sense. Because you want to suspect that the terrorist trying to spread this disease will engineer these organisms to be inherently resistant to the more common bacterial agents. So you want to suspect that there's resistance to beta-lactams when choosing empiric therapy. And there's another expression, never let the sun set on a anthrax effusion. I don't think there exists something like that, but there should. So they say that as soon as you get an effusion like that, you drain it, keep draining it until it gets better. And you may need corticosteroids if there's any concern about cerebral edema. There are some immunotherapies involved. There's an anthrax immunoglobulin made from the plasmapheresis of those immunized with the licensed vaccine. If you were to use this, you would do so as an investigational new drug. They're stockpiling it, though. The U.S. Department of Homeland Security is also stockpiling Apthrax. So a lot of these drugs have a lot of funny names, but I think this one is probably the one that makes most sense, Apthrax, also known as Araxibacumab. And there's a modified 5-dose regimen of a vaccine. You give it at 0, 4 weeks, and then you give it at 6, 12, and 18 months. Those are for people that you really want to prevent from getting pulmonary anthrax. There's yearly boosters after that. If you want to give it as a pre-exposure prophylaxis, you can give it as a pre-exposure prophylaxis to veterans, workers, and those exposed, but there's a shorter immunization schedule that could be used with that. Post-exposure prophylaxis, those are the initial antibiotics that they recommend. If you eventually get susceptibilities and there's penicillin sensitivity, you can transition to amoxicillin or penicillin. It's probably easier to do it by the above regimens than Q8 hours or Q6 hours, though. But you treat for 60 days. This was a problem with a lot of the outbreaks that occurred in 2001, because there were thousands of people that needed this. But it was so difficult to get these people to keep taking these antibiotics for as long as they should, because they didn't really feel as though they needed it. So there was a huge problem with compliance. If you are going to prophylax someone post-exposure, you can give them the vaccine, but you give it at 0, 2, and 4 weeks, and you have to use it as an investigational new drug. Now, I got this from Mendel. He says you can actually put these people in a standard hospital room with standard precautions. I don't know if I would ever do that personally. Maybe I'm just not cavalier enough. But you can potentially do that. You can just continue cover the cutaneous lesions, cover the output from a chest tube, blood, bodily fluids, and everything that's exposed, incinerated, or autoclaved. You do not use ethyl alcohol-based hand sanitizers, hand wash. Use a lot of bleach-containing or chlorine-containing product. So the next is a diagram, I believe. So imagine this is an office that's really well ventilated. and you're at ground zero. Let's say there's someone who's trying to release these spores, and he gets to ground zero and releases these anthrax spores. The numbers that you see are time in seconds. So by the time those spores are released, it can reach those parts of the office in 96 seconds, 240 seconds, 192 seconds, and so forth. So within that short amount of time, we can see the whole office becoming infected. If you're actually concerned about someone getting pulmonary anthrax, the CDC has a lot of resources available in which you can go through a diagnostic algorithm and see what their risk is of actually having anthrax. They also have pictures. If you're worried about cutaneous anthrax, they'll show you examples and try to talk you through whether this is a cutaneous anthrax or whether this is related to another type of infection. This is some tool that you can use to really find out what to do when you're trying to assess someone for pulmonary anthrax. We're not really going to go through this that much. You can look it up. There's probably more better pictorials from the CDC. So that's probably the most alarming that I thought. Now, the next one that we're going to talk about has some probably relevance to popular cinema. So this is going to be another question and answer thing. So, has anyone seen this movie? Yeah? Did you like it? So there's some relevance with our next disease. So I don't want, if you're worried about a spoiler, you should probably cover your ears. But the cartoon's been out for years. There's really no spoiler. So let's be adults. So we don't really know about Belle's mother in the whole cartoon version. However, in this movie, we actually find out what happened to her mother. So the Beast and her went back using their mirror to a distant part in time where we get to see her mother, and he lifts this mask, and he obviously knows what happened to her mother. To find out what that is, does anybody know what this is and what it's used for? Does anybody know? The plague. So it's an interesting mask because it doesn't really do a whole lot, but they put a lot of spices in where the beak is to just keep the smell out. And a lot of these people aren't really doctors. They're really out in the field to assess the involvement of disease. And they carry around walking sticks so they don't actually have to touch the people that are infected. And you did read that right. It is on Etsy, so if you feel so inclined, you can buy these online if you'd like. I don't know why or who or what, but it's actually available. So it's a plague. That's going to be our next disease. So the Mongols used to actually throw bodies of plague victims over the walls of cities in Italy when trying to fight for control. Now these ships from that port took them to other cities, and from 1347 to 1354, you had the Black Death, killing just up to about 1/3 of the population. During World War II, Japanese were responsible for so much bioterrorism. If you actually look back into it, it's just a little bit alarming. They dropped clay pots with plague-filled fleas into China. In the 1980s, there was a Soviet defector who eventually revealed that they were making genetically antibiotic-resistant forms of the plague that can be aerosolized. So Yersinia pestis, it's an aerobic gram-negative Bacillus with bipolar staining, and at 72 hours, it can also display a fried egg morphology. So this is a peripheral smear, and you can see the bipolar staining in the organisms there. So it's endemic in 17 contiguous western United States, and the animals involved, ground squirrels, prairie dogs, chipmunks, rodents, and it's active from May through October. So rodents, feline, canine predators, if you're in contact with them, you're at a higher risk. And travelers with the plague can go from one place to another, and it's going to be tough to find out where this originated. And so that's called the peripatetic plague, potentially. So this is a cluster where you can see the disease. This is the routes of transmission, but we won't go too much over it. So the incubation is between 2 to 7 days. It's sudden onset fever, chills, headache, malaise, and you develop a bubo, which is a swelling of a regional lymph node, groin, axilla, neck that's painful, and you can see ulcers and eschars near the bubo. I'm not even sure I'm saying that right. Bubo. You can get a septicemic plague, which is a fairly rapid onset, and you don't see a bubo. Rapidly progressive, and it leads to overwhelming sepsis, multi-organ failure, and death. This is why it's called the Black Death. and they feel as though that may be why it's termed as such. But the one that's most involved with bioterrorism is pneumonic plague. Within 1 day, you can see the disease. Secondary pneumonic plague is when it goes from hematogenous spread or bubo to the lungs, or you can actually get primary pneumonic plague. And that's the one we're concerned about with bioterrorism. You need a microbiology diagnosis, but you can get titers too that can help you diagnose the disease. This is one of those where streptomycin is actually useful, but it's probably not the best option in the grand scheme of things. Alternative is gentamicin with doxy. And if you are really worried, you can potentially use levaquin or chloramphenicol, but that's more with meningitis, pleuritis, or myocarditis. And prophylaxis, doxy or levaquin for 7 days. So that's the plague. So the next image, I'm going to ask you what these particular images have in common. If you can come up with a diagnosis. Yeah, you got it. So Dr. Castro correctly said tularemia. I want him to get credit for it. So tularemia is a next disease. Francisella tularensis, small aerobic catalase positive, pleomorphic, gram-negative coccobacilli. There's 4 species, but the most common subspecies that's really relevant is tularensis and holarctica. 10 to 50 organisms are all you really need to get infected when inhaled or injected intradermally. It's more common in June through August with tick-associated disease, and in December with more hunting. So there's a lot of occupational hazards involved with this disease. This is all the places that it has occurred. From rodents, squirrels, voles, muskrats, beavers. They usually get it from fleas, arthropod bites, but you can get it from the animal itself. And in Martha's Vineyard, there was an outbreak with mowing lawns and brush cutting, probably with inadvertently going over animals that were infected. You can get a lot of varying manifestations of tularemia, but the more common ones that we're going to focus on, not more common, the more relevant ones, typhoidal and pneumonic. So typhoidal is when we get a febrile illness with prominent lymphadenopathy that's not associated with other forms of disease. You can see a pretty rapid death with this manifestation, and you can see hepatosplenomegaly in later stages. Pneumonic tularemia is what we're worried about, with direct inhalation of anywhere between 10 to 50 organisms. And you can see it in association with typhoidal and ulceroglandular tularemia, but this would probably be more secondary. And you can see varying levels of infiltrates. And the problem with this is actually diagnosing it, because it could be related to community-acquired pneumonia, could be related to other infections, could be related to TB. So it may be later on that we eventually find a diagnosis and go with it. This person got a chest x-ray, and he was symptomatic for more than 3 months before they found out that it was tularemia. Treatment, mild disease, you can just use Cipro or Doxy, 14 days. Moderate to severe disease, they say you can use streptomycin, gentamicin is another option. But in meningitis, you have to combine streptomycin or gentamicin with either Doxy or, in other countries, chloramphenicol. The role in bioterrorism is likely in the setting of aerosolization, and it's going to be tough to really diagnose because we don't really think about it as often. And sadly enough, children may be more vulnerable. They have a higher respiratory rate, they have a more skin to mass ratio, and more skin permeability. So to prophylax against it, we can use Doxy or Cipro for 14 days. And children, a general rule here is that children should not routinely be given prophylaxis for routine exposures. But when you're talking about bioterrorism, you kind of have to throw these side effects kind of out the window, because the risk of bioterrorism and disease and death far outweigh the potential of side effects. So if you are suspecting a bioterrorist scenario, they do recommend you can use Doxy or Cipro. And that leads to a lot of the major ones. I could have talked about a lot more, but unfortunately we don't have a lot of time to talk about a whole bunch more. So I thought maybe this could be a part 1 and part 2-er, but we'll see. But I thought this was relevant, particularly in our global climate, to talk about the bioterrorism aspect, along with some of the more common diseases that we can see. But the question to ask is, what are potential future infectious disease emergencies? So you have to think about how it can spread quickly from one to another, affect a huge amount of people, and be easily transmissible. So the one thing that really comes to mind, it has been really popularized in cinema also. So we're going to go through some of these. Has anyone seen this movie? World War Z? Does anyone know what the Z stands for? Zombies. Then we have other popular movies. Resident Evil. The sixth one actually is coming out, or sixth one, seventh, the last one. And FYI, if you want to kill zombies, that's probably not what you should wear. We have the Walking Dead, still out now. It's gotten a little too gruesome for me though. And we have I Am Legend. So in this case, it was actually a virus that he was using to treat cancer that caused a huge outbreak, and eventually the world got infected with this virus, became zombies, and there was a small cluster of people that were alive. So how big of a threat is this? You may think, oh, it's probably nothing. But the CDC doesn't think so. So they say to get a kit, make a plan, be prepared. So there's actually this thing on the website that advocates for preparedness. Now, I think they're just joking. They don't really think that there's a zombie apocalypse, so don't be that scared. But they want everyone to create an action plan, make sure they're ready in cases of catastrophe. And so that's what the whole purpose of this was. So they have a zombie task force also along with their website that you can join. And they go through things that you would potentially need in the setting of this outbreak, and what you would need to have stockpiled in case of emergencies. So they help you go through all that. But this isn't just for zombie outbreaks. It could be for anything, natural disasters, things as such. So I think that's it. But we went through a whole bunch of them. There's a lot more. There's a lot broader characterizations you can make about what classifies as an infectious disease emergency. But that's kind of a potpourri of what we can see with more of a inclination towards bioterrorism, because I think that's pretty important to talk about. I think that's about it.